Good evening, everyone. My name is Natisha Smith, and thank you so much for joining me for Kaplan's second webinar in our series focusing on racial inequality in medicine. In tonight's series, we're going to be discussing the history of experimentation on people of color. Joining me is our amazing panel, hello, starting with Dr. Kathy Williams, who is a practicing dentist, Kyle Goebel, who is a second-year medical student, Rhoda, a director of operations for Kaplan Educational Foundation, Dr. Elon, and Dr. Nicole Sparks. How are you all doing this evening?
Good.
Doing great.
Thank you so much for joining me, and thank you so much for joining me around this very important topic. The topic that we're going to be discussing this evening is one that is not wildly known. So to get us started, I'd love to hear a little bit about each and every one of your entry points to understanding this history of experimentation of people of color and what that term even means to you. Dr. Nicole Sparks, I'm going to start with you. Can you tell me the first time you encountered a story in medicine that was shocking to you?
Well, unfortunately, I will say that the first time I encountered, any history of medical experimentation was too late. I have expressed before on social media that I believe that at the beginning of medical school that there should be more teaching on implicit bias and on the history of experimentation on people of color. And one thing that I recently shared on my social media, which I was really surprised that nobody knew about, is basically what, the father of modern gynecology, James Marion Sims, and how he actually, used and experimented his enslaved women. He actually bought them for that purpose to actually practice on them. And these women came to him with fistulas, which of course, he should fix, but his purpose to fix it wasn't, for their benefit, it was for profit. And unfortunately, he did that to these enslaved women and did it without anesthesia. And after he actually perfected his procedure, he then opened, a nice hospital and for white women and only operated on them with anesthesia. And when I revealed that, a lot of people were like, I can't believe that. No, that didn't happen. And, the sad thing is it did happen. And what's even sadder is that no one actually knows about it. So it's like, why are these stories hidden? Why is nobody telling us? Why is nobody teaching this to us? Why, as someone who wants to go into OBGYNs, that I learned this entirely too late. Why, if I went to my medical school class, would no one be able to actually, tell me about this? No one would actually know about it. And so I would say I was probably exposed at the very end of medical school / beginning of residency, like I said, which was way, way, way too late.
Dr. Williams, you expressed a similar notion when you and I connected around having to do your own research and sort of stumbling into this buried history of experimentation. What is something that stands out to you in one of your first moments recognizing that this was a broader issue?
So a lot of people are afraid to go to the physician, afraid to go to the dentist, afraid to go for any medical procedure. And my question was always why, right? Like, why do we have fear? The disparities exist because of what has happened historically. They don't teach certain things in medical school and dental school, like presentations, like how things present medically. They teach it on white bodies as opposed to Black bodies. So for me, like in dental school, we had to have, when you get dentures, we have to choose your teeth color, we have to choose your gum color, which we call gingiva. And so there's a specific color for African Americans. It's called Meharry light, Meharry dark. And it's more so purple as opposed to pink because Black people have a darker gingiva color. And I'm from New York City. All of my training was done East Coast, New Jersey, New York City. My training was also done in predominantly Black neighborhoods. But when I moved to the West Coast, for some reason, no one knew about this Meharry color. No one knew that they had to choose different colors of the gingiva. They just everyone wears pink. And it's like, why isn't this taught like globally? Why am I the only one who knows this? Why is it only taught on the East Coast versus the West Coast? So just so many disparities, so many holes that just are interconnected. It just doesn't make sense to me. So I started to do research on my own, not limited to medical exploitation, but I just kind of fell into a rabbit hole of medical exploitation. And I read a book by Harriet A. Washington called Medical Apartheid, where I just learned a lot of information of a lot of egregious acts that we will probably touch base on within this talk today.
So one of the terms that you just used, I want to touch on a little bit more before I pass this question to our next panelist, is medical exploitation. And in listening to Dr. Sparks speak, one of the things that even came out in talking about the history of gynecology was the lack of anesthesia used on Black bodies. And so I think one of the threads that is important to touch on is when we say that there's a history of experimentation of people of color, we really mean that it's a detrimental experimentation, right? We know that to move science forward, there have to be experiments. That's part of the process. But actually the thing that we are talking about is a racialized and violent experimentation on bodies of color. And so Kyle, I know that this is something that specifically has come up for you. Can you tell us a little bit more about your entryway into this topic?
Sure. So as you were just speaking, I thought about how when we talk about experimentation and sort of exploitation and what the line is between those two things, the idea of non-therapeutic research is really kind of what we're talking about. For example, in the case of Marion Sims, of J. Marion Sims, was there a potential benefit to curing vesicovaginal fistula in the enslaved women? Sure, but without using anesthesia, with restraining the women, et cetera, you lose sort of that like benevolence that we sort of think of when we think about medical research or just medicine in general. So, for me as a medical student, I'm a second year medical student. I go to a medical school that has its own significant history in this. It's actually mentioned by name in Medical Apartheid, and Medical Apartheid for me is sort of where I really kind of dove into this as a sort of self-study. When I was an undergrad and graduate school, I probably heard about Tuskegee a couple times, but always sort of as like an afterthought. There was never really like a deep discussion onto what that meant to the history of the United States and of medicine and of the Black community specifically. So it's kind of murky for me to remember exactly where I encountered it for the first time, but it was definitely not in a formal educational environment like in medical school, for example. So like I mentioned, reading Medical Apartheid is really kind of how I started to understand just how far this history went beyond Tuskegee, beyond J. Marion Sims, even beyond Henrietta Lacks. These are all sort of stories that I think a lot of us are familiar with by now. These are obviously really critical events of American history and of medical history, but I think some people would argue that they were one-offs, and they would attribute them to sort of like the last few overtly racist scientists and physicians in medicine and public health, but that's obviously not true. So, when I read Medical Apartheid, it sort of like solidified my suspicion that all of the like previous work and formal research I had done was incomplete, specifically when I think about health disparities. So, I remember I was reading this book actually around the time that I was sort of reconsidering a career in medicine. And I was thinking about going to the medical school I go to, Medical College of Georgia. And I remember, again, reading the stories about MCG in the book and just thinking to myself, like, wow, like, if I decide to go to this school, which I did, are they going to talk about it at all? And so when I was on my interview, I actually asked about it because that's just the kind of person I am. I was willing to take that risk. And I said, what happens now? Like, what do you do now to sort of like recognize and rectify that history? And, we talked a little bit about how there are yearly ceremonies for the body donors that we dissect in our first year. But that was sort of it. There was really no more discussion after that. And I was really extremely impacted by that rite of passage, the dissection in the first year. And so reading the history while also doing anatomical dissection was odd and very troubling and difficult. And I'll probably speak a little bit more later about sort of some more about that and kind of what's going on at MCG now, some positive things.
Thank you, Kyle. Two threads that are coming out are sort of these two parallel tracks in the impact of this history. And one of them is that what do our future doctors learn, and how do those learnings, or like lack of learning and sort of buried biases, impact care? The other is, what does the common person know and understand, and how does this impact communities and how communities react to care being given to them? Rhoda, I want to turn to you because I know that Tuskegee is a story that you are familiar with. What was your entryway into learning about this as a Black woman, and as a Black woman who supports lots of students of color and communities who represent people of color?
Definitely. So undergrad, I did major in chemistry and molecular biology and biochemistry, and I was so sure I was going to be a doctor. And I do remember my mother, she is an Army nurse veteran who served in Vietnam, and she used to tell me, back in the day, they used to say, don't fall asleep around Johns Hopkins. So this is something in the Black community that has been, people are aware of this. And so I think the point where, yes, I'd heard of Tuskegee, but when she handed me the book, The Immortal Life of Henrietta Lacks, in really listening to the story of this woman who, I think Kyle had said, there's no therapeutic end to the treatment, right? It's just purely how can you test on somebody, and to see how to read that and be like, this can't be real. But then as a Black woman, how I interact with the medical community. I remember being in Brooklyn trying to find a primary who looked at me and said, well, gee, you must be the only Black woman over 25 who doesn't have any children. And starting to see the thread that that's how this happens. And for my students, so when I was in school, you either majored in biology or chemistry if you were interested, but now there are more interdisciplinary majors like medical anthropology, where the students are confronting this right in the front door. And so one of the things I've seen is that students are not only taken aback by how bodies are used, but they start to see how little they know about their own bodies and how they've been kept away of being able to learn how to advocate for themselves. And some of them are in the situation where they are the only English speaker in their family, where they not only have to bridge this gap for their community, that they're trying to understand, like, who can I trust? And I can say that it's exciting to see that there are more opportunities for students to engage with this from other lenses other than just the hard sciences. But I can see that there is a huge gap. And now with COVID and other things happening, people are so resistant. And you see college presidents that are trying to encourage more Black community members to engage in testing, but the resistance is there. So now we're at an impasse where history is now confronting science, and there's a lot of work there that needs to be done.
Thank you, Rhoda. One of the things, Rhoda, as you were speaking, I started to think about is just sort of this generational impact, right? That for every time that there's this pocket of communities and that we experiment on, or that we disenfranchise, that then impacts their future generations. And so before we sort of move deeper into the stories that we know and what we do with it, I would really actually like to pause us and sort of take us back to, how did we get here? And what were the historical and social factors that have led to this being both prevalent yet hidden at the same time? This is a big question, and I don't think we all have all the answers. And so know that I'm asking this so that we sort of engage in the discourse of, from where we're standing, what are we seeing? Dr. Lawn, I want to start with you. As you think about this history, and in some ways, ongoing history of experimenting on people of color, what has led that to be a practice that is being enacted in medicine?
Hi, Natisha. Yeah, I'm very, interested in what Rhoda said, what Rhoda's mom would tell her about not falling asleep near Hopkins. As I was reading part of the history of experimentation in the South and around the 1830s, and medical schools were the biggest even the way that they were trying to get students to come in was by advertising how many bodies they could have and provide for their studies. And it all had to do with how close they were to Black populations. And one of the things that people would say around those times, like around 1830, was exactly what Rhoda's mom would say. Somebody would say, I would rather die in the summer, because during the summertime is when medical schools were closed. And so then if you die in the summer, then you would get buried. If you didn't die in the summer, then you were likely to be part of the bodies that we use for dissection. And so I think it's so interesting that even in those, like, all these years, the same sort of stories are being shared. And that tells you something, doesn't it? I think when we think about the Tuskegee experimentation and the reparations that have happened, I think it was Bill Clinton at some point that gave, all this money back to Tuskegee, and so they have this new medical center and all of that. But none of the people who were really affected by these studies or their families had, I think, have any sort of real recognition of, like, hey, we did this horrible thing. And so I think there's a narrative here, certainly of many years of not even addressing the things that have been done yet, and so add that to the fact that healthcare is sometimes really hard for people to get in different populations, where education is not happening correctly. And so all you hear is about maybe the Tuskegee, I think, is very famous, but even the data for this, sometimes the stories get a little mixed up. And so some people, and if you don't have the background in science, and if you don't have the background of and the privilege of, like, higher education or whatnot, then these stories become something even more, horrifying. Because, I can't trust a system that I don't know. I'm going to go to the doctor, and what are they going to put in me? Are you for real telling me that this test is going to, tell me that I have COVID, or are you taking my DNA? Like, I used to do testing for COVID in the beginning of the pandemic, and I had a lot of people ask me this question: what kind of test is this, and why are you doing this? With a lot of, like, I'm not sure that I want to do this kind of attitude. And I understand now why, with all of these things that are not being acknowledged. You have to start somewhere, and I think acknowledging that we've done as scientists some pretty terrible things is one way to start.
Thank you, Elon. Dr. Sparks, I want to sort of pull this question to you, as you have shared the story of the history of gynecology and the lack of anesthesiology used on women of color, and specifically Black women. Part of me thinks, why would they think that that's okay? And part of me knows the answer as a Black woman, but I would love to hear your perspective on what factors you think led to that choice being made. But then also, something you said earlier really stood out in terms of how long it took for you to learn that. What factors also lead to that not being written directly in the medical books that students are seeing?
Well, a lot of that comes from just theories that were held long ago that are actually still held today. So, Black people, don't feel as much pain. We have thicker skin. Our, blood coagulates differently. Like, these are things that were held as beliefs many, many, many years ago. And, there are some quotes from Marion Sims that said that, the enslaved woman, just basically how they were able to hold it together. And as Kyle stated, while his cohorts actually held these women down. And I just feel like it actually permeates today. And, we know that the maternal health in the US is atrocious. And what I want to emphasize to people is that we always blame it on, oh, well, they're poor and they're this. If you remember, they have done studies. You can control for income and you can control for socioeconomic status, and the stats are still the same. And they are only the same in the US. So if you look anywhere else in the world from 2000, 2017, the maternal health stats are actually getting better in developed countries. Not in the US, okay? Not in the US. So you have to say that something else is wrong, because me, as a physician, as a high income earner, I still had a preterm baby. Why is that? So you have to think that there is something ingrained that is happening, and it comes, from way back when. And for example, we've all been talking about medical apartheid because it's a necessary read, but part of it talks about, like Dr. Alon said, how basically Black bodies were used for medical schools, and the more bodies you had, the more people wanted to come there. But they also recommend different treatment plans. So for example, they give an example of a child who came in with a leg ulcer, and the doctor amputated the leg for all the students to see. and specifically said that, if an enslaved person is to come in, you can just cut off the leg, but you need to recommend better treatment options, especially if they're a white man. And these are things that are actually written down. And this holds true today. So my patients will come to me and they'll say, well, I was only offered this, I was only offered an open hysterectomy, when we have plenty of minimally invasive options. Black women are not offered the same treatments depending on, their provider. And, I know we'll get into this later, but part of what I think we need is, number one, we need more Black physicians and Black NPs and Black nurses and all of that. There's a quote from a doctor, an article that I read that says, implicit bias is odorless and colorless to everybody except for the victim. So, no one else realizes it, but the victim is who suffers when your treatment plans are altered, or you don't realize that you're offering this to her. But if she went to someone else, they would offer her something different. Or if she was a white woman, you would give her more options. You give the Black woman one option while the white woman has 8. And that is a problem. And I think that, we have to call it out. We have to, and I would love to hear more from Kyle about what his school is particularly doing. I want to hear what a lot of schools are doing, because what are we doing? What are we doing so that we are breeding a new, a breed of physicians that are actually going to change the narrative? I don't want it to be 20 years from now and I'm still saying, oh, well, Black women are 3 to 4 times more likely to die than their white counterparts. We've been singing the same story for years. So what are we going to do about it? And I can't do it by myself. I, of course, make sure that I do my little part in my office and in my community, but I can't do it for everybody else. Everybody has to take, stand and recognize it and call it out for what it is.
Thank you, Dr. Sparks. One of the things that you really touched on, and then Kyle, I'll pass this to you, since also Dr. Sparks called you out directly, so I have to make sure we get your thoughts, is that, and I think, Kyle, you actually use this terminology, that we view these as isolated incidences. So this thing happened, and that was horrific, and that was atrocious, but that was this one doctor in this one area, or that was isolated to this mentality in this specific set of time. What gets lost in that narrative is to what Dr. Sparks is pointing out, and what Dr. Elon's pointed out, and what Rhoda's pointed out, is this long-term impact, both on what we teach, how we care for people. And so, Kyle, from your perspective, what are you seeing that feels the same, and what are you seeing that feels different or progressive in this space?
It's interesting because history is sort of like it seems like a slippery kind of subject, especially if you're not a professional or like academic historian. We've all kind of heard that old proverb, history is written by the victor. And in the United States, in medicine, the victor is the white physician, right? The white male physician in particular. And so, just in general, the American medical establishment as a profession has enjoyed a lot of autonomy and a lot of privilege, social prestige, financial security, et cetera. And to this day, it's still very much a white man's space. The AAMC puts out its data every year, and it's, dismal numbers that are totally not on par with what the population of the United States looks like. This is evolving, and I know there are efforts to actively increase workforce representation, but as a student, it's interesting because I can talk a little bit about kind of what's been going on the past few months. I'm the chair of health policy and legislative affairs for our chapter of SNMA, of Student National Medical Association. And for those who aren't familiar with what that is, the National Medical Association is the sort of professional organization for Black physicians and other minority physicians in the US as a, sort of collective voice. And the SNMA is the student offshoot of that, of course. And so part of what has been going on these past few months over the summer is, after the murder of Ahmaud Arbery specifically, that happened just minutes from one of our satellite campuses. And so the minority students were very, very fearful at that time, because we knew that having a white coat would not necessarily be protective against that if we're outside just jogging, for example, as is the case with Ahmaud. And there was deafening silence from a lot of medical schools, including my own. And we got together and said, okay, well, this is unacceptable. So we're going to take a little bit of a professional risk, and we're going to write a letter, a call to action, and we're going to just put it all on the table. We're going to list a series of things that we need to have a discussion about and that need to be changed, because we have to make a decision as a medical school that was founded in 1828 in the American South. You do the math and, figure out what that means. What are we going to do as sort of the last major touch point of a generation or a group of 200 physicians per year who are going to be out there in this extremely awesome responsibility of being able to heal and also having a very, very high potential to do harm? What are we going to do to make sure that we are putting out people who are not doing harm, especially harm that is due to racial bias? And so part of what we kind of advocated for be included in that letter was to just acknowledge the history. Again, the history that we've already been discussing of grave robbing, and also using slave labor to do the grave robbing so that the physician could be distanced from that and the physician would not be held accountable legally. Keep in mind that grave robbing obviously is still illegal, always has been illegal, but anatomical dissection of dead bodies was illegal in the United States until the later part of the 19th century. It was illegal, even for medical purposes, for study. So it was done under cover of darkness and illegality in the middle of the night, things like that. And it happened, for decades and decades. And so, my school was not immune to that. It happened, and there's documented cases. And in fact, in the 90s, there was a widely publicized story of the discovery of thousands of people's remains underneath the old building that were thrown, among the trash, among the broken glass, et cetera, in a mass grave. And it was publicized. Everybody knew about it. And so we had, we're having actually regular conversations right now with the deans of our medical school. What are we going to do about that? We need to include that history. Every medical student, every resident, faculty member who comes through this school needs to know that history. It needs to be part of our anatomical dissection curriculum. And there's another story as well that I'll just briefly mention about a woman named Bessie Wilborn. And she was a Black woman who died of Paget's disease, which if you know anything about Paget's disease, it can be extremely disfiguring of somebody's skeleton. And so she died in the early 1900s, and her body somehow came into the possession of MCG, and her daughter alleges that there was no permission for that. And so eventually when her daughter got older, she sued, because MCG was using her body as a display, basically, to say, there was a case report published by the physician who was treating her. So he got a benefit from that. And the daughter said, how did this happen? You owe me now. You need to be held accountable for that. And the Georgia Board of Regents said, okay, we'll give you the remains, but you have to drop any, claim to financial damages or settlement. And of course, her daughter said, no, that's not acceptable either. And to this day, as we speak right now, Bessie Wilborn's body is still in possession of the Medical College of Georgia. So we are actually this year, this is part of our letter, we are actually right now in the process of trying to finally give her the burial that she deserves, in conjunction with the community, with the faith community and her family. So it took significant sort of collective voice on the part of students to do this. Students who we're just trying to learn medicine. We're knee deep in up to our eyeballs even in hematology this week, for example, and here we are doing this work instead at the same time. So, it's the history is buried, it is completely ignored, and the outcome of that is significant harm, which is antithetical to the oath that we take.
Thank you, Kyle, for sharing that and being so open about the work that you are currently doing. One of the things that we continue touching on is the need for direct confrontation with the history of how we have treated bodies of color and the mistreatment of those bodies. Dr. Williams, I have a question I want to pose to you, and this is an audience question. A question from the audience is, since intergenerational trauma is taught primarily to those who experience it, what can medical students do to combat intergenerational trauma? Dr. Williams, do you have any thoughts on how medical students can understand that intergenerational trauma and what they can do to better combat it?
it's difficult to teach what you may not already understand. It's hard to learn things for people. So we've had courses on medical disparities, and yet doctors still go out into the world and still treat Black people unfairly. So to answer that question, for me specifically, the reason why I even went into a medical profession was because I already understood. I understood health disparities. I've been treated poorly by physicians, by dentists. I've had people not understand me, not understand my pain. So I get into the head of my patients when I'm treating them. I feel like we need a curriculum that is engraved into our courses, just like Kyle mentioned, where we have to expose the egregious acts that have been performed just so that they can understand it, so that they can become empathetic. Because no, you don't want to mistreat people. You don't want to harm people. That's most people when they go to med school, it's like, why do you want to become a doctor? Because I want to help people. It's hard to teach empathy, but people react to discuss, people react to egregious acts. So in order to do that, we have to teach the history. And a lot of the reasons why no one knows anything is because history is not taught. Therefore, history is going to repeat itself. So just to backtrack, we just have to teach the history to our medical students. And it's difficult to incorporate that because even the physicians who are teaching don't know it. Like we've mentioned, we had to seek out this history ourselves. It's so difficult to even find this information. I do a lot of research, and within looking for this information, you have to be a physician, one. A lot of this stuff is buried in medical articles. So you have to be a doctor to access these articles. You have to pay for it. And then you have to decipher it because it's difficult to understand. It's jargon. So how do we get there? That's not an easy question for me to answer.
Thank you, Dr. Williams. I think for sharing those barriers, right? Because I think part of the question that we have at the core of this is like, how is this buried? And the barrier of who gets to write the books, who gets to decide who's worthy of humane care, and then who gets access to information and who has the tools to decipher the information. Those are very big barriers to navigate and uncover. So I think it's important to call them out directly, because I think by stating them, then we can at least start to build the tools to navigate them. We are getting lots of great audience questions, so thank you, audience. Something I want to pivot us to is we've been talking about a lot of this in terms of historical context, but something that continues to seep through is that it is not historical. It is happening. It is living history that is continuing today. This feels very apparent to me in two specific scenarios: COVID, and also current conversation on the COVID vaccinations, and the recent story that broke out around the forced hysterectomies of immigrants within ICE. So we want to tackle both of these. These are two things that our audience has been asking about. We'll start with COVID, because I know that has been a 2020 challenge, and it is one that has disproportionately impacted Native American, Latino, and Black communities. As a vaccination is on the horizon, there's lots of questions on how communities of color are going to react to a vaccine, and whether or not this sort of history of distrust, right? And even if, my uncle or mom can't name half of the stories you've just said, Rhoda, I think, pointed out that there's still this understood distrust of the medical community, right? Even if you don't know where it comes from, you have a feeling of, don't go to the doctor if you don't need to, or don't take this medicine if you don't need to. But that is challenging when communities are dying from a pandemic. So I want to sort of get all of our perspectives on this. Rhoda, I'll start with you, because I know that you have been working with people impacted by COVID. How do you feel like the communities that you've seen are currently navigating COVID information and may feel about the vaccination coming out?
I think you hit the nail on the head when you talked about distrust. For a number of the students that I work with, they have had to navigate a lot of challenges within their families. And for those that have lost parents, the medical community that they interacted with was not kind, did not offer a lot of information. So I think at this point, it's difficult to try to rehab this long extending issue between how communities interact with the medical field. And I think it comes down to representation, which I think is what other people have said. People trust what they can see, and they trust who they see. And I think to that point, until non-white members of the community, Black, brown, are seen as peers instead of props, we're going to continue to have this issue. If you're not going to, to me, the doctors that you see talking about this on national stage, I have not seen any that were not white presenting. So if that's who's, delivering the message, even if you do have HBCU presidents who are Black saying, come join me, people are going to be like, okay, in the 5th round of that, please. So I think you ultimately have to demonstrate that the medical field is one that embraces people of color, not just as props to figure out how to treat white patients, but also until you have a body of research that reflects the diversity of people in this country. In a pandemic, I'm not sure how you're going to be able to quickly bridge that. I mean, I have students that I don't think they were able to collect their family remains. I'm not sure if they've even been able to collect their father. You know what I mean? So, and then you expect them to trust that system. I had a student that her medication was like, here's a card. Thank you for donating your medicine to the COVID pandemic. I mean, that if there's no unity in the message of understanding that the medical field is there to help people and not make money, people are going to continue to not want to engage.
Thank you, Rhoda. Dr. Alon, I want to pass this to you because I know that you've both worked with COVID and also have been closely following the story that broke around ICE immigrants. What are your thoughts around what's happening today and how we navigate the distrust that communities of color are feeling?
Well, I mean, what is happening in the ICE detention centers is part of, like, reflects part of the story that we've been talking about, where it's disenfranchised people, enslaved people, people who have no mourners, no representation, who are the ones who are always affected by decisions of this kind. What's happening in the ICE detention, what the whistleblower is saying, is part of what I think Dr. Sparks was referencing, where the only doctor who's, and I'm not sure who this doctor is, but the only doctor that they're using in this facility, the only option that they're giving these women in the detention center is a complete hysterectomy for heavy bleeding, which is absolutely not it is recommended in some cases, but not for all cases. So it's the same kind of situation where people who have no standing then are submitted to whoever is making the big decisions for them, which is horrifying to me. In terms of the COVID situation, we have to start. I am very concerned because the amount of politics that are involved now in our healthcare system is beyond. I think it's a huge problem, because how are we going to have trust in any vaccination that comes our way when we have the president of the United States telling one thing and some other people saying a different thing, from saying that this virus is a hoax to all of this. So it doesn't really matter where you stand on politics. There's very little faith or very little trust in whatever comes our way. So I think that we are going to have to do a lot of hard work in educating people. First of all, as a physician, I want to know what this vaccination is, and so transparency, I think it's going to be vital for us, medical people, and so we can see what it is that they're basing their results on. I want to read the studies, so I before we start recommending, and then we can do, as an outreach, then we amplify whenever we have the information. I know that I have a lot of friends and family who look up to me, and it's sort of like, if I say we go, then we go, But at first, I need to have some trust also in what's happening, and I feel like transparency is super important. We need politicians to step away from this and leave the truth of science to speak, so that when the time comes and if it's available, then we can do the education, and it's going to take a lot of effort, I think, from all points, so that people can trust again what we have to say.
Thank you, Dr. Alon. Staying on this topic of distrust, another audience question that we're getting is, we've been talking a lot about how the medical community needs to contend with their history. It needs to change practices. I think that's very important. But Dr. Williams, I think, made really good points that there are lots of layers that we need to unpack to make real progress there. So one of the questions coming up is, with so much distrust, specifically in this question between Black people in the medical field, what is your advice on how individuals can advocate for themselves in situations where they don't feel like they're being heard or believed? And Dr. Williams, I'll start with you, but Dr. Sparks, I'd also like to hear from you as well.
Well, my first piece of advice is, don't believe everything you read on Facebook, right? Because I feel like that's where everyone is getting their information from nowadays. And we live in a digital age where we can just Google things and look it up and just become informed that way. The way that I learned all of this information is via Google, reading books. If you want to become informed, you have to inform yourself. I mean, the information is out there. You got to look for it, but it's out there. I just finished watching the documentary, The Social Dilemma, and they spoke of like what Facebook algorithms present to you, like the ads, the information, the Facebook groups, everything that appeals to you, they're just going to keep putting that information in front of you. And I like to look at things from both sides. So I like to and I don't want to get political, but as far as like Democratic and Republican parties go, I look at things from both sides. So I like to have all of my information there from both sides so I can piece together my own opinion. And I just do the research, like if you don't trust vaccinations, don't go to these actually go to the anti-vaccination groups and see what they're talking about. And then look up your own piece of information as to why vaccinations are effective. Just don't take everything with a grain of salt. Do your own research. Make sure you know exactly what you're talking about, what the information is talking about. Make sure it's credible information. And that's how you can pretty much figure it out for yourself.
Dr. Sparks?
So advocating for your health is something I always discuss with my patients. And like I've stated before, I don't think that the responsibility needs to be on the patients, because as the providers, I feel like we need to be armed with this information and be able to protect our patients. But in most of these cases, we're not. And so I just feel like, in any visit, anything that the physician is talking about, like ask for clarification, speak up. If something doesn't seem right, I tell people it's okay to get a second opinion. My friend was telling me about how she, had a cyst on her ovary, and her physician recommended that she have a big open surgery, which is not actually standard practice. And she went and saw someone else who was a Black woman who recommended a less invasive option. And so I tell people, don't ever be afraid to get a second opinion. You are not married to your doctor. So if you don't agree with their plan, you can just go find another physician, or you can just confirm or deny what they've said. And if you want to come back to them and say, I've gotten a second opinion and this is what they've said, then fine. Ask questions, I find it surprising the amount of people who come and they have no questions, but you're about to have this big procedure, you have no questions. You should always ask, what are the risks? Before I had any of my surgeries, what are the risks? What are the benefits? What is the potential that this will work? How successful is this? Like, you should actually be asking all of these questions. I think it's time like we take control of our health so we don't continue to have these statistics. And so I really just tell my patients, just really kind of take control, ask the necessary questions, speak up for yourself, seek the opinion of somebody else. If you, and it's not just if you don't like your doctor's answer, but if you just feel like something's not right, it's probably not. And, a story I just read about, I reread because he popped up on my feed. But a lot of us know about, I think her name is Kara Johnson, where she went in for a standard repeat C-section and ended up having 3 liters of blood in her abdomen. But the thing is, she was at a really big, renowned medical facility. And over the course of 10 hours, let her doctors know that she was in pain. And her, her cries were kind of ignored. And, I've had some patients that say, well, they don't want to be seen as like the angry Black woman. And they don't, if you're like demanding this, and it does have to be a delicate balance, but at the same time, if it's life or death, you have to choose your life. And so, even this, and Serena Williams talks about how they didn't believe her, that she had a blood clot. Like, this is what we face in reality every day, is we're not being believed. And, this comes from way before, where enslaved people were thought to, when they were really sick, their masters just thought they were malingering. Those same things from history comes way down into today. Those same thoughts from way back, 20, 30, 40, 50, 100 years ago are the same things that are thought about us today. And so, I know everybody doesn't have this advantage, but when I went to the hospital for an emergency and I felt like I wasn't being hurt, I quickly pulled my doctor card. I was like, I'm a physician. This is what I think I have, and I need to be seen because this is actually an emergency. And then I was seen quickly. But why did I have to do that? Why couldn't you just take my concerns seriously from the minute I walked in pain into the emergency room? And so, like Dr. Williams said, there is so much that has to be unpacked. But, the medical student who asks what you can do, you can do your part. You can earn the trust of your patients and let them know, because there is a distrust. And there are some people who will not go to any doctors, but they especially won't go to a white one. And not all white physicians are bad, and not all Black physicians are good, but I feel like if everyone does their part, and, and like Kyle said, we took an oath to help people, and I forget Rhoda, who said, see us as peers and not props. We were literally seen as experiments. When physicians back in the day, they would help, some of the slaves get better, but a lot of them would buy slaves just so they could practice on them. They would ask, give me a slave with kidney stones, give me a slave with this liver problem so I can specifically practice that. That is not what we are about. And I think that kind of thinking has kind of come to today, and we are not for experimentation. You need to care for your patients. And so that's kind of what I want to get. I know we probably have a lot of medical students on today, and that's what I want to get across is your patients are not experiments. I know it's cool to see like some new cool disease, and oh, that's cool. That is a patient. That patient is more than their disease, and you need to see them as such. And I think when you start to see them as such, and you put your family member, yourself in their shoes, that's when you actually become a better provider. We can't teach you compassion. We can't teach you empathy, but if you just learn to be a good person, and, the knowledge will come. Anybody can learn, all these books I have behind me, anybody can read that. That's not what makes you a good doctor. I study next to people who I wouldn't working on my dog, like, but I just feel like it's more than just the books. Okay. You have to actually care about your patients. And I really want to get that across to the medical students or anybody, in the medical field who's watching right now.
Thank you, Dr. Sparks.
If I could, I wanted to kind of keep that going a little bit, and just say that for any medical students who are listening, or anybody who's pre-med, there's a certain amount of like willingness that you'll have to decide for yourself of like how much professional risk you're willing to accept. And this is speaking now of you as a professional and not as a patient. What I mean by that is there's a certain amount of risk associated with speaking truth to power. It's very, very unlikely that, those of you who are going to be matriculating into medical school soon, or other professional programs, that American medical history, for example, is going to be a part of your curriculum, as we've been discussing tonight. However, this obviously doesn't mean that you should just accept American medicine the way it is, because clearly there are significant problems. Just look at any major health indicator of the United States. We spend the most money on health. I mean, we could go into a whole argument about just how American healthcare is delivered and how it's not very successful in many ways. But if you're willing to accept that risk, and tonight I'm even putting myself a little bit on the line by talking about my school and the way I'm talking about it. And I'm not here to indict my school. I'm here to protect the integrity of my school and to protect the integrity of this profession, this spiritual calling that is about healing, right? It's not about getting a degree or being successful and making money. This is a spiritual job. And I don't mean that in a religious way. I mean, human to human, the art of healing another human being is inherently a spiritual work, right? So if you're willing to accept a certain amount of risk, to say what needs to be said, to write those calls to action, to call out the bias when you see it, because you will see it. You'll see it in the way that questions are asked of you on exams. For example, Black race is listed as a risk factor, as if race alone is a risk factor for a certain disease. And with very few exceptions, there are some genetic predispositions that you'll associate with very, very rare diseases in certain Jewish populations and certain Caucasian populations, whatever. Those are definitely the exception. And when you hear race listed as a risk factor, that's a sign that whoever is telling you that has no idea what they're talking about. What they mean is that racism is a risk factor, societal response to that person as, with a certain skin color, that is what puts them at greater risk for certain chronic illnesses, for example. So you're going to see a lot of that. And you have to be willing, again, it's up to you, but you have to be willing to put yourself on the line to say what needs to be said to your colleagues, your fellow students, to professors, and maybe even to the deans of your medical school, which is not easy, but it's necessary. That kind of goes into the story I was telling earlier. So it's important here, I think, also to recognize that there is a minority tax. It's unfair that we are the ones carrying this burden of trying to protect the integrity of this profession and of, the art of healing. But we're all familiar with that and we all feel that. So, it's up to you kind of how far you're willing to go with that risk.
Thank you, Kyle. We have one question that I want to make sure we touch on because I think that it touches on the sort of, to Kyle's point, the tax and how that tax can start to compound as you are a person of color and a woman, or a person of color and a part of the LGBTQ community. So the question that we received was, can any of the panelists speak to intersectionality in medical exploitation, particularly in the context of patients who are people of color and part of the LGBTQ community, perhaps? Dr. Elon, I know this is something that is particularly near and dear to your heart, so I wanted to pass this one to you.
Yeah, I wanted to follow up with what Dr. Sparks and Kyle also were talking about, because I think this needs to be a concerted effort. For instance, in the topics of intersectionality, LGBTQ people have had to, I think in the latest studies that they're made, more than 50% of LGBTQ people are having to educate their doctors when they go to their office. And I find that to be, as a physician, I've had this experience as well, as a non-binary person, having to explain to a doctor what that means. And I have the ability because I am a physician and I know how to speak for myself, but that is not the case. That there's so much trauma, there's so much isms associated with all the different groups that you belong to, that is really hard to speak up in the presence of someone who has basically their life in their hands, your life in their hands. And so I feel like it is incredibly important that we need to tackle this from every angle that we can. And that means that students need to, medical students need to demand more from their physicians, from their educators. And us as physicians, everybody who has anything to do with healthcare needs to educate themselves. It is true that doctors never cease to study. And I agree with Kyle. For me, medicine is an art. And you have to be cognizant that a person is not only that knee pain that comes to your office. A person is their environment, is their family, is where they come from, what they believe in, what they know. And we as doctors have to take all of these things into consideration. The only way that we can move forward is if we all try together to get better and be better. And that means studying, and that means listening, and that means understanding that all these assumptions that I had in the beginning, maybe I'm wrong. As a doctor, I can be wrong. And I think there's a lot about the culture in our hospitals that do not allow for doctors to say, well, maybe I didn't know about this. We need to have the humility, and we need to have the wisdom of saying, I need to learn more. And so I think this is an effort that has to come from both students who are being formed right now, asking our professors to be part of this new way of doing medicine, because otherwise we're not going anywhere. And COVID is proving just that.
We're somehow at our final 5 minutes, so I could listen to this panel speak all evening. So I have 2 last questions that I'm actually going to have all of us answer, because I would love to hear from each of you. The first, I'm going to ask it as it was sent to us, but then I'm going to sort of provide a different take. So the question is there some sort of system of accountability in place that checks physicians who make decisions based on implicit and explicit bias? How often are racist physicians held accountable? I'm sure there's lots of things we can say on that question, but I would actually be most interested in hearing the system that you would like to see in place. Like, what does the future of a more equitable, anti-racist system look like that puts patients as people first? And so what system of check and balances would you like to see us move towards if the one that is existent is not a great one? Dr. Williams, I will start with you. I know this is a big question. You get the fun of starting us off, but I will start with you.
I think Dr. Elon touched on this, and doctors are placed in a world where they don't feel like they are wrong, or they're embarrassed to be wrong. And it's not necessarily a bad thing. When I don't know something, I'm very honest about it, and I say, I'm not sure. Let's look that up, or let's get you to another doctor so we can figure it out. As far as implicit bias goes, we all have our biases, but you just need to get into the communities and get to understand your patients more, get into your patients' heads, understand where they're coming from, get more empathetic. And then we can get rid of implicit biases. And I think I missed something else. So can you repeat the question? I apologize.
So the question is, what's the system we would like to see in place that holds doctors accountable for racist treatment of their patients?
I feel like doctors need to be called out on it. And I feel like no one ever calls doctors out on it. If a patient leaves an office and they feel as if a doctor if they had a racist encounter, they never really tell anyone. If they can tell their family members, but they never tell the community. Now, I'm not going to advocate for cancel culture, but I think they need to be canceled because you know when you're doing something wrong, you know when you're being racist. So we need to start calling them out. And as a Black doctor, and in San Diego, where I'm one of maybe 3, I speak to other doctors, other physicians, and they say things to me that kind of catch me off guard, and I'm never able to correct it. It's like sometimes I'm like a deer in headlights, like at some point a doctor told me, oh, like, it seems like you have a great upbringing and you have good grammar. And it's just like, wait, whoa, but I never correct it. And I feel like sometimes we should correct people because they may not necessarily know what they're saying is hurtful, what they're saying is wrong. They may know it, but no one ever calls them out on it. So if we start correcting people, if we start checking people as a patient, as a colleague, we can probably get somewhere.
Dr. Sparks, same question, though I want to add a layer here, which is, do you feel that doctors have insight into discrepancies in their care? So are white doctors or just doctors in general aware when a specific demographic is receiving less care from them otherwise? Is there potentially a blind spot and like doctors not being able to see that they are not delivering the same level of care across the board? And sort of tying this to like implicit bias to what you're saying being odorless, how do we help doctors recognize when their implicit biases are impacting their patients?
Well, I would actually prefer the physician with explicit bias. And I do think some physicians are just, they are who they are. But like I said before, because implicit bias is kind of sneaky, kind of just sneaks its way around. And, even the provider doesn't realize what they're doing, until it actually, somebody said, how can they be held accountable? It's kind of hard to hold people accountable if there's no, a Black person receiving less treatment for pain than a white person is not necessarily something that we can prove or show or, get you fired for. So everything, it's, it's little things. I do think it needs to start at the head. I do think on an individual level, we can do our part, but this is why we need people like us in the boardrooms making the big decisions, because, like Kyle said, if someone's, at the head and making it a part of MCG's curriculum to actually learn about this, then that's how people learn about it. So I can easily say, well, go read and go do this, but really we need the people in power actually making some of these decisions that are going to impact on an individual level. There is only so much that we can do alone, but we need people in these boardrooms who are going to be making these big decisions that are going to impact our people. And I just want to say one thing, because I'm looking at a question that says, what advice would you give undergrad African-American students, especially females who are pre-med trying to help change this narrative? One word, and I preach it once a week on my Instagram, and it's called finish. It's called finish. It's called complete. This is coming from the girl who got into one medical school, and that is where I am today. So I tell people, like, the road is hard. Kyle can talk about it. It sucks. I can go on and on about how much it really does suck. But I tell Black women, we need you. We need everybody, but we really need you, because I'm tired of the statistic that 2% of Black women are physicians. I'm like, okay, we get it. So let's fix it. So what you can do as a pre-med and a Black woman is actually finish. Is when it gets hard, you still finish. And when you want to give up, you still finish, because we need more of you. And, if we have more Black doctors in Arkansas and Kentucky, then you can actually help, instead of, patients having to drive 80 miles to go see the nearest Black physician. You can be that next physician who goes to these areas that need help. So finish. That's my one word. You need to actually finish. And when you want to quit, I want you to go back to this day on September 22nd, 2020. And remember Dr. Sparks telling you that you need to finish, because we actually do need you. And that's said with all the love in the world.
I think I saw Rhoda snapping, and I was like, yes. Rhoda, I will pivot to you. As someone who receives care, what is the system of accountability you would like to see moving forward?
I think it needs to be two-pronged. Like for me, I am a huge researcher. So when I go to the doctor, I sign up for that online portal. I make sure that I bring my tablet, and I have my, I come with my tests. Like I recently had to go to the ER, and they were trying to tell a story, and I was like, let's come here and let's read this together. I'm gonna show you right here where my doctor said it. And I am one of those women who drives an hour to have a Black woman doctor because of my history. I think it's that you incentivize behavior. There's no reason for people to just all of a sudden be like, I'm going to care for my patients. For me, I was on ZocDoc. I was looking at ratings. I was looking at reviews. I think that you also need to make sure that people understand you don't have to take what you're given. Like I tell my students, the way you buy those sneakers, seek your doctor. So I think you need to make sure that people, I think Dr. Simino was on another panel, discernment. Because we've made education a commodity, there's a whole section of our population that cannot engage in the conversations that we're having right now. How do you make sure that everybody here is educated on how to be? We all have bodies, we all have lives. Like having to be, if you don't have a mother who's a nurse, like watching my father's end of life stage after they gave him a kidney biopsy he should have never had because they missed, he had a rare form of sickle cell. It was a Black woman hematologist who figured this out. Is when I made it my duty that you have to understand that I'm not holding out for the whole medical education system to be fixed. I think once you make sure doctors think that they have to earn the trust, not that you're going to get referrals, earn the trust, that you have a review. Do you have something? I mean, you can go to McDonald's and they'll ask you, how was your Big Mac? Does anyone ask you that at the doctor's office? Is there a record for the doctor to be able to have an evaluation from the hospital to say, oh, okay, I see all the people here keep saying that you rush them out and you don't care. So until the system itself says that it is its responsibility to provide the services, that we're all paying all this money out of our taxes, for healthcare. Let's not talk about it after COVID, they're gonna come for everybody's pocket. So when is it going to be that the system itself? Because as to your point, Dr. Sparks, people need to finish. I didn't finish. I was not supported when I was pursuing this. And so I hope everyone out there is getting the support they need, but you need to refix it from the ground up. Until you have ratings on these doctors, until you have reviews, until these reviews are public, until that I can go to a hospital and say, I need this type of surgery. Can I see the ratings on these physicians so I can select from this menu since you are charging me? Until that exists, this will continue. And also to the point about getting second opinions, I had someone from HR who came and supported me. Let me tell you, some of those second opinions are free through your insurance. So pass that little tidbit along, but also I will put it to the consumer until they fix this, the way that you go by that purse, right? I want you to think about your doctor like that because you don't have to take what people give you.
Thank you, Rhoda. Dr. Elon and then Kyle, and then we will wrap up. And thank you all for sharing your time and your thoughts with us this evening.
Oh, I think it's, it's part of the what everybody's been talking. I think the representation is very important. And so we need people from all walks of life. We need non-binary doctors, we need people of color, we need brown people, we need making the big decisions. They need to be included in every part of the hospital life, in every part of the healthcare system, in every part. Well, RPG said it. Women need to be where decisions are being made. I think everybody needs to be where decisions are being made. I think that's what I would like to see, is doctors who look like me when I go to see my doctor, who understand what I'm going through. I want my friends to have doctors where they can relate. There's something about that that needs to happen. And so, yes, to what Dr. Spark said, finish. To all these people who are there, if anybody needs support, please contact me. I'm like, I want to support anybody who's struggling right now. And this is part of what we do, right? As we progress in our careers, we also need to be available for the people who are starting. And so I'm making this also a public statement. If anybody needs any sort of want to have conversations, want to have one-on-ones, medical careers are hard. Let's talk about it. Let's figure out solutions together. I think we need to create that feedback loop so that we can start making things a little bit better.
All right, so I'm not sure how much more I could add to, really like a very difficult question to answer, but also one that's not so difficult in my mind in some ways. And I'll go a little bit upstream. And what I think about is who should be a physician, right? And we talk about this a lot as far as like recruitment into medical school. And, just having recently gone through that process a few years ago, they cared about, a score I got on a test that probably did not really measure my actual intelligence or knowledge at all. In fact, every week when we have a quiz, I tell my friends and colleagues, I say, remember, this quiz we're going to take on Friday morning is nothing more than a snapshot in time of your knowledge right now at 8 o'clock in the morning. It doesn't tell you what you knew yesterday. It doesn't tell you what you're going to know tomorrow. It has nothing to do with your character. It's just a snapshot in time of, over 300 slides of material. They're going to pick 20 questions. Maybe you get lucky and you knew that one. Maybe you didn't. And so, also with the NBME changing step 1 to be pass fail, with some medical schools because of the pandemic actually taking the MCAT out of their recruitment process. I think that there is a paradigm shift that the ideal part of me thinks is happening. The more pessimistic side thinks it's not happening fast enough or at all, but I think it's absolutely needed to totally change how the medical establishment views sort of who should be a physician, what a good physician is, what does professionalism mean? We have a lot of coded words when we, think about professionalism and sort of the behaviors that we ascribe, the knowledge, skills, and attitudes we ascribe to good physicians. But what does society actually think a good physician is? What do patients, what do real people think a good physician is? And oftentimes those two ideas or conceptions of what a good doctor is are separate and different, and they shouldn't be, right? Because again, in my mind, when I took the oath and got this white coat, and I'll take this oath again when I graduate and before I start residency, I sort of came to understand my role as a healer. It's not a job or even a career. I don't even call it a profession, but it really is more about it's a name, an identity. It's like a promise I'm making to the world. If I clock out from the hospital and go home and somebody passes out on the street, on the sidewalk on my way home, do I say, oh, I'm not a doctor right now? Absolutely not. You get down on your hands and knees and you do something to help that person, because you have the ability to do so with not just your knowledge and your skills, but your compassion. So I really think that we need to kind of revisit what it is, sort of that gate at the beginning of medical school. Like, who do we allow into this space? How do we sort of define or discern like who has that sort of altruistic capability? Who do we think can develop that capability if they don't have it right now? It can't just be based on the easy stuff, the low-hanging fruit, like a good test score or good grades, because those don't really mean anything at all, especially in the context of what American education is. So I think that this paradigm shift has to happen. And if I had, an ideal medical school that I ran someday, that's what it would be. Is I wouldn't care so much if you failed a class. I wouldn't even care if you got a DUI necessarily. I wouldn't care if you had tattoos. I wouldn't care if you already had children, or you had been divorced. All these things that seem to be like the bane of professional physicians' existence, that would not exist in my space, and I think we would be better for it.
Thank each and every one of you so much for engaging in what is a difficult, challenging topic, one that takes a lot of personal learning, a lot of emotional energy to learn things, and then to continue to have the empathy to both engage in a system that is not set up for your success as an individual, professional, and then change that system. I'm hoping that everyone in this audience today has heard something that empowers them to learn more and do more as we push to make a more equitable medical system. I want to thank all of our panelists for their time this evening, and thank you to all of our attendees in the audience. We will see you soon in our next session, which will take place on October 15th. Thank you and have a good evening.